Hello, and thanks for asking me to come. I've been given the very exciting task of talking about the third Scottish Dementia Strategy. Are we all aware of the fact that we have a third Scottish Dementia Strategy? And I'm going to find it very hard to follow the three talks that we've heard already because they've all been absolutely fantastic. And I think that the example that Philly used of the right to get out and about is a really, really good example of how the deep network can make a difference and change things positively from that really solid experience of living with dementia. So, this is a hello to yourselves from a cross-section of the deep network in Edinburgh a couple of months ago. And the most fantastic thing about that event, it was the third of 3 events that we ran. It was amazing fun, but it was also extremely profound. And when I wondered how I was going to approach talking about the Scottish Dementia Strategy without falling asleep, while I was thinking about how I was going to talk about it, I thought I'd take a bit of a different approach to some of the presentations we've had already, and just feedback, comments and insights that I've picked up and people have made to me from deep groups and from deep networks and from deep gatherings over the past year, and many of them relate to the strategy. So that's a really good group of people, and that's right at the end of a long working day. Philly, you were there as well, weren't you? Agnes, you were there? A little bit of spiel about us. We are part of Innovations in Dementia, but DEEP, as Philly said, is a network. It's not an organisation, it's a network of individuals and groups of people, and those groups are led by people living with dementia. Rachel is that one, and I'm this one. We're the 2 coordinators, and I have the north of the UK as my responsibility, and Rachel has the south and Wales. We're both part-time, and that means, as somebody in Oldham said to me, we're too busy to be bossy. And I think that's one of the fantastic things that gets said after a long discussion, because that actually sums it up perfectly. And while we were agonising about should we have more time, should we have more coordinators, that really solidified it for me that my role is to coordinate and facilitate, not manage. Because DEEP is not about managing groups of people, it's about facilitating and enabling. So we stayed where we are. So there are contact details, and all these presentations are going up on the site anyway, so they're all available. If you want to get a copy of anything, come to me, and also go onto the website if you want to pick stuff up from the website. Everything we talk about is on our website as well. So, as Billy said, we're a UK network and we connect people. In Scotland, as in England, as in Wales, as in Northern Ireland, there are groups, but there are also fantastic networks of individuals who link with each other as well. So we have a sort of gathering network as well that's built up from the gatherings that we've held. As I say, there's over 80 groups. There's a bit of a dispute. One of our tasks at the moment is actually to tie that down. Everywhere from South Uist to Exeter and most places in between. We're an independent voice of people's experience of living with dementia, and that's one of the criteria for a group to join the DEEP network, and must be focused on influencing and informing attitudes. It's about being positive and creating hopefulness, and of course promoting human and dementia rights. And it's amazing, I've been involved in the network just for 16, 17 months now, but it's amazing to see how the rights agenda has just flowed up from the ground upwards and has become a really main theme of what we do in the DEEP network. I'm going to give you quite a lot of quotes from people. When we planned our 3 Scottish gatherings, we asked a group of people to come and help us set the criteria for what they wanted. This really meant something to me. There's a lady who'd never been to a planning meeting before in her life, living with dementia in Kirkintilloch. She summed it up by saying, as long as everything's clear and tidy, and everyone's kind to each other, it'll work out. And in a sense, there's your dementia strategy. I'm not being silly.
No.
We can say things, people say things very, very clearly. And how much of that do we actually find in the dementia strategy? It's a difficult document to follow. So Scotland's dementia strategy, third dementia strategy, sets out three main challenges, and I've summarised them here. Timely, person-centred, flexible support for people living with dementia and their carers across a range of settings. Person-centred care and support throughout the course of, and I put it in parentheses, the illness. I'll come back to that. To continue to redesign and transform services in the community, and to also to ensure that palliative and end-of-life services are flexible and responsive to individual needs. Well, you can't actually fault any of those phrases, can you? Okay. Is dementia an illness, or is it a whole range of syndromes and conditions? I find it quite alarming that it's referred to as the illness in such an important document, because it's a much bigger philosophical definition than that, as we've heard today from people's own testimony. So, a quote to balance that: it's important to get the correct diagnosis. Dementia is not enough. There are many kinds of dementia which can benefit from different medications and interventions. You wouldn't just say to somebody, you've got cancer, and send you away. We have the right to more specific information. So that would be a response to that definition of the illness. People want more specific information. Also reflects what Agnes was saying earlier about other conditions get very specific responses. So the dementia strategy is focused on improving services. It's service-centred as a document. It's not a person-centred document. It's about how do we fund, run, manage, monitor, evaluate, design services. And its underpinning structure is Alzheimer's Scotland's 5-pillar to 8-pillar to end-of-life care pathway for dementia, which is sort of set as the accepted Scottish national pathway that people will go down if they have dementia. And I and others, Agnes included, have been at meetings of the cross-parliamentary group when we've questioned, as you heard earlier, how many people do get that post-diagnostic support during the first year of their diagnosis. And there have been all sorts of discussions around that table. Well, most people do. Well, if people don't want it, we've got to find out ways of persuading them to get it. So we will say, well, maybe people don't want it in the first year. Maybe people want it 3 years later. How does that work out? Well, we think people should have it in the first year. So what evidence actually supports this basic structure for the way that the dementia strategy is built? One of the important evaluation documents that helped the Scottish Parliament to write their strategy was done by Blake Stevenson, and it was published in July 2017, just before the strategy was written. It's up there. I'll put the web address at the end of the presentation for you. And I picked out 2 quotes from that, and it says that the data, it was about evaluating the 8-pillar model of home care and the 5-pillar model of home care, the whole pathway. So that it says in this report that informs the strategy, the data is based on a relatively small sample, and the time periods for each area are not completely identical. That makes it difficult to draw out much meaningful interpretation that could be said to apply more generally. And then overall, the perception of those interviewed is that patients do not really fit into the overall model of 5 pillars, a period of self-management, followed by 8 pillars, integrated support, followed by an advanced stage support, ... However, that model is what the dementia strategy is based on.
Awful.
No, quite right, absolutely. Okay, so evidence again? No. So, do you mean my presentation or the strategy? I just thought, yeah.
We've got some tomatoes for the other one.
Yeah. I'm trying to jazz it up, believe you me. Yeah. So, that's all right. They're off.
We said it'd be provocative.
Yeah, so as Agnes said earlier, And this was during Agnes's project, where we had the first videoing session last week, interviewing people. I tried to cross the bridge of self-management. I think it's a fantastic image, between the 5 pillars and the 8 pillars, and it collapsed. It's not there. The support in that middle period, if you don't go for the first year post-diagnostic support, there is nothing there for people. That's the reality, that's the feedback from people on the ground. Without a self-directed support toolkit, we are being done to, and we are not in control of our lives. And that reflects things that have been said earlier today as well. So the self-directed support toolkit, the self-management toolkit, is one of the things that Agnes and the alumni will be developing through their project, which we're proud to support, very proud to support. The Blake Stevenson report and a lot of the input that went into the consultation meetings for this strategy refer a lot to the Life Changes Trust and its funded projects, one of which is Deep. But the strategy only makes a very slight reference to the Life Changes Trust and to dementia-friendly communities, other than to say that there should be more. The strategy emphasises the clinical or the care pathway, the medical model. It's based on the medical model of dementia as the illness, which, to my mind, I don't know how you feel about it, be provocative, is a very inadequate way of describing dementia, because it's a personal experience. It's a set of conditions. It's not an illness. And for me, I find that disturbing. The strategy makes hardly any reference at all to rights. The only references I could find to rights were in the equalities commitment. I think it's commitment 15, if I remember. You'll be glad to know I've written them all out for you, so you can all have a copy for the workshop that follows this. And it's focused mainly on ensuring access to services within the equalities framework. So saying that people, quite rightly, people from an LGBT background or a learning disability background that are affected by dementia, or the different ethnic strands and cultural strands, should all have access to dementia services, which is not the same as a human rights agenda. It's different. I couldn't find any other mention of human rights in the document at all. Correct me, I'm sure you'll all read it word for word. And it's also focused very much on ensuring access to services and workforce issues, training the workforce, staffing the organisations that already deliver dementia services. Sorry?
No. Organisation.
Organisation.
No.
Okay.
One.
Yeah. Well, no, indeed, I'll come to that. Don't steal my thunder. Yeah. The strategy includes no reference to the complex issues of capacity, proxy and supported decision-making, or other legal issues. There's a whole complex network of legal issues and capacity rights. There's a huge discussion going on in the Scottish Law Commission in that whole arena about what capacity means, what attorneys mean, what a guardianship means, how long it should be granted for, what's the role of a guardian, etc. The balance between proxy and supported decision-making. Crucial to people living with dementia, but they're not mentioned at all. A quote from the Deep Network: "We will achieve person-centred care when it's related to human rights." So, just picking holes, just little holes in the strategy, which is what I was asked to do. So commitment 15 says we'll support implementation of the NHS Health Scotland's report recommendations on dementia and equalities. I've put the web address for that particular document at the end of this presentation as well. And again, it's a good it's a great document, talking in terms of the NHS. That document's fine, but it's about the NHS. It's about a medically based service for people with dementia. It doesn't relate to any other kind of strategy at all. So, that's fallen off the bottom of the page. I thought for the workshop that follows, we could look at these priorities that have come from the Deep Network and balance them out against the commitments of the Scottish Dementia Strategy. We held, as I said, 3 gatherings in Scotland, and we've had lots and lots of other meetings as well, where we gathered people living with dementia and their carers or family members and 1 or 2 facilitators in 3 venues, one in the south of Scotland, one in the north of Scotland, and one in the middle of Scotland, because they are actually 3 very distinct territories. We've got people travelling from all over the place, coming by bicycle and bus and aeroplane and boat and coach and train. I don't think anybody actually walked. You didn't run all the way, did you, Philly? No, okay. Swimming, yeah, a couple of swimming experiences, yeah. Yes, there was, wasn't there, in Inverness? So I've simply listed the priorities that came from those gatherings. Our right to get out and about, which completely reflects what was found in the north of England, and seemed to come top. And that means that people want to be and have the right to be part of the community. It wasn't initially our right to get out and about, it was just getting out and about. How do we get out? When the light comes on that we have a right to get out and about, as Philly eloquently said, it reframes the whole question. The reduction of stigma, again, both stigma from outside and internal stigma, all the aspects of stigma. Improving diagnosis and medication experience, and that's the process of being given a diagnosis and the relationship with medication. So people feeling that they have to take medication or they can't have medication, and a lack of a person's right to actually say, I don't want that medication anymore, I don't like that medication, I want to know more about the medication, etc. We've been asked to draw up a receiving diagnosis guide so we can give it to doctors, how people should be told they have a diagnosis. Addressing bullying and victimisation, where it might occur on a local level as well, particularly that came from. Support all the way through the dementia journey, which reflects the bridge in the middle, the self-management bridge, as a priority as well. And the huge disparity right across Scotland. For example, in the Western Isles, there was no post-diagnostic support given for a period of about 2 years. Do you know why that was? There were no link workers. There was no funding for any service. And so the figures are very skewed. So it was quoted before, James said, I think 60% of people don't get post-diagnostic support. Depends which figures you look at. Connecting and reducing loneliness using technology, creativity and community. Well, we've taken steps on a number of these, in fact, when we look back at these priorities. The right to self-management. The right to be supported to live independently in the community is what that has become, and which has become the alumni project, but also has repercussions throughout the deep network and hopefully beyond. Because the deep network is linked to lots of other circumstances. Some of those groups are part of Alzheimer's Scotland, some of them are independent groups, some of them are NHS groups, some of them are local authority groups, some of them are completely independent groups like the alumni. Doing normal things, doing what we want to do, came through very, very strongly. Just doing normal things, not having to do everything within the context of having dementia, living a normal life. Using our culture and creative opportunities to enhance our lifestyles. The right to keep our relationships going, and this was a really, really interesting topic. Yes, Joy?
Can you explain that a bit more? What do you mean?
Relationships.
Relationships going.
There was a lot of discussion, we had a lot of discussion about the fact that if I have a diagnosis of dementia, my wife will be my carer, and you've had that experience yourself. Whereas it's important that my wife remains my wife. My mum has Alzheimer's, I'm her son. First and foremost, I'm her son. So it's about keeping those relationships as they are, and reducing the huge pressure for those people that we love and love us to be our carers and have that formal role. And beyond that, to have the right to relationship support, which you mentioned earlier as well, to keep those relationships intact, because it comes up later, we often hurt the ones we love. And even the vet counsellor, as you referred to earlier, Joy, as well. But about keeping the relationships going. And that's a move on from conversations that we previously had, which were about carer responsibilities and carer rights. It's bringing the right to have our relationships. It might well be that my wife is my carer, but she's still my wife. Agnes?
And a lot of things have been talking about that, but always remember that not everyone has people.
Yes.
Right, and you know, people who live alone have the right to relationships,
Yes.
be it their NIPB,
Yeah.
you know, and that is not being taken into consideration. The government assume that everyone has got a carer,
Yeah.
you know.
And not everybody does, no.
No, and
That's
we
right.
have a right to have, and what you don't talk about either is, my husband and I both have
Yeah.
dementia,
Yeah.
but we don't get any relationship guidance on
Yes.
how we can keep a relationship.
Yeah.
They decided the best thing we could do was live in separate houses.
Yes.
So I live in the family home and he lives in a flat. But we had a right to keep our marriage, but that was ignored.
Yeah.
So that is why it came up,
Yeah.
you know?
So these issues all came about from discussions in groups about this size, or twice or three times this size, and became the priorities in the right of people who live in care settings to have relationships as well. Yeah. Gathering together, people meeting people was the way it came out in the end. Just regularly, as often as possible, getting together to share concerns and have fun, as well as very informative fun. Because it's amazing, you could see it from that photograph. Nobody was paid to smile on that photograph. They could have all gone home, but they didn't. Clear, accessible information and understanding. So people should be keeping clear guidelines. It relates back to diagnosis as well. There should be clear information for people, simple, accessible information at the point of diagnosis and ongoing information. And people living with dementia leading research, initiating research, being co-researchers rather than just being research subjects, which is a very passive role. And we've already started to see some of that happen as well. So some more quotes. I want to see a world that accepts dementia. Living with dementia is a journey. You can find new ways to use your brain and learn to outmaneuver dementia. And how many of those coping strategies are shared with people? But people who have changed their lives, your film on sensory challenges has some fantastic examples of that, doesn't it?
Yeah.
Yeah? Dementia is mainly loneliness. You can find community in all sorts of places, not only in dementia services. And that's something that I uncovered looking through notes, and I think that's a very powerful thing to say. When we think about people who've stopped communicating, we have to ask ourselves, how much is that due to loneliness and abandonment, rather than necessarily the cause of the illness? We are still the same person, we just live in a different way. And this illustrates the point earlier, connections between mum and daughter, husband and wife can get very difficult. We have a right to relationship help, not just through the lens of dementia, because sometimes we hurt the ones we love most. Join us in our journey of hopefulness. When I told my doctor of all the positive things I was doing, he said, "Now Maria, you must understand that you will not get better." Why did he have to say that? So the diagnostic and prognostic evidence may say that things are getting worse. So a lot of research material, a lot of medical material will say that the course of dementia worsens. It's based on loss, what you will lose. The loss of self, the loss of mind, for example. That's the language it's often framed in. Better get your attorneyship and you will sort it out. Very negative picture. But the narrative of the person, like Maria, might start to say, well, things are actually getting better. I feel better. As James famously said, a lot of people think that a diagnosis of dementia is the end of the world, but I actually enjoy my life more now. We meet people all the time who are getting more out of life than they had done before. That's with peer support. That's with a positive attitude. Deep doesn't try to tell us about dementia, Deep listens to what we have to say. That's a very significant thing for me to have heard people say, and something to use as a cornerstone. Listen to the quiet voices. Now, this was said in terms of somebody who's experiencing dysphasia and whose voice gets quieter and quieter and quieter, so finds himself excluded from meetings because that's the way his dementia affects him. But then finds that people don't listen to him anymore, people don't talk to him anymore because they can't hear what he's saying. But it also kicks us into one of the areas that we're trying to prioritise, which is giving a voice to people who live in care settings, who are perceived to be affected by advanced dementia, and find a way of giving people their voice in that context, but also as part of the Deep network. People living with dementia, as you've clearly seen today, can contribute and help to change the world for everybody in the future. These are very, very positive messages. Yeah. Some other deep responses to the strategy. Not all from people with dementia, some from people that facilitate groups and professionals. People felt that it demonstrated a lack of ambition. I personally thought it felt rather tired, like rehashing the same kind of stuff. A move right away from a bottom-up approach of dementia-friendly communities. There's hardly any of that in there. No detail about any of the planned actions on the commitments. Not saying we'll do this first, saying we should have more dementia-friendly communities and we'll do some research into showing how we can do that. People don't feel that's necessarily a strategy. No commitments to family carers, just referring to their needs. No mention of prevention, despite all the evidence that could advise policy. So it's very much a containment and management strategy. It's not a positive saying we can prevent dementia. We can take this initiative. We can try this. We can research into that. There's no mention of that. Not that I can find. If you're not diagnosed early enough, will your needs be met? And we've heard testimony today that they might not be. If you don't want post-diagnostic support in your first year, can you have it when you want it? Well, at the moment, no, you can't. There's a lack of consistency with discussions that we felt we'd taken part in the consultation events. A lot of that stuff hasn't been carried forward into the document. And the final version was heavily influenced by a closed group of people that took all the hearsay, sat together in the ubiquitous smoke-filled room, said I'd get provocative, and wrote a strategy that met some needs, organisational needs, one might say. And somebody else said, well, why do we need a third strategy? What was wrong with the second one? I believe Scotland might say that it's leading the world, but as far as I'm aware, it's the only country that's needed a third strategy. Why? Why not a review of the second one? Why not an update on the second one? What was this drive? Well, a cynic might point at many causes for that, but it's still a very, very valid question. There was an off-the-cuff remark by a person who was leaving a meeting. Yeah? The person with dementia. Oh, that's fantastic, I'm writing that down. Yeah. Dementia is not always about older people and memory, it's also about sensory challenges and dysphagia. Using creative and cultural opportunities and thinking outside the box to make sure that people with very quiet voices can be heard. The third Scottish Dementia Strategy mentions all the important elements, but reads more like a business plan for the principal providers, that being the NHS, local authorities and Alzheimer's Scotland. In fact, that's what it is. It's a business plan for those three organisations. And it's service-centred, it's not person-centred. Not everybody, as is evidenced even by the Blake Stevenson report that spoke to 11 people living with dementia, 11 people, accepts the inevitability of the care pathway described because it doesn't meet everybody's needs. It simply doesn't meet everybody's needs. Somebody I love very dearly has dementia. She's 90 years old. She's never seen a support worker in her life. She had her assessment and she chooses to live completely independently and survives. We all know people like that, don't we? Yep. So DEEP is the Dementia Engagement and Empowerment Project. That's what DEEP stands for, although we don't actually say that very often anymore now. It represents a social movement. Some people say it's dementia activism. Some people say it's the quiet revolution, and it's long overdue. It's turning the world upside down in the kindest way, saying this is what people experience and this is what people want. Surjit, who came to the Edinburgh gathering, is 94 years old and is supported by a fantastic network of Asian women, some Muslims, some Hindus, some Christians, some atheists. But they're Asian women, that's their identity. And a number of them have dementia. And that group told us that deep in Sanskrit means the light from the lamp of enlightenment. And that's why they were interested in coming. So deep creates very positive and magical connections. Thank you. Those are the addresses for the documents that I've alluded to, if you want them. Yeah.